So objective
We'll start by the bowel.
We'll start by the bowel ultrasound. So the objective of today's session is to talk about the technique and what is normal bowel. What is the technique, how we do the ultrasound, and what is normal bowel. We will also record it, and you can hear it again. Sounds good?
Please, yeah.
Okay. So there is two types of bowel for assessment. There is large bowel and there is small bowel. The large bowel, we swab it, we look at it in inverted Y-shaped scanning, starting from lower right, going up to the liver, and then to the other side to the spleen and going down. Swabbing the small bowel like looning a garden. When you do your loon, when you cut your grass, you go and back. You go, so you cut everything, so you scan. So the best way to do both, to do it in sections. So we have right upper quadrant, left upper quadrant, left lower quadrant, and right lower quadrant. With each, you can do perpendicular and transverse. And then with each, you do 2D view or gray view and color view. Okay?
Okay.
So again,
yes,
you do 4 quadrant in addition to the umbilicus. With each view, you do perpendicular and transverse. And you have to do 1 color Doppler. And the best to record the clips for at least like 5 seconds. So in addition, instead of pressing freeze, then print, you just press save. When you don't see and you see air, and when you see air, you will see the reverberation, the mirror imaging, okay, and maybe you see cometel. So when you see air, you have to do 2 things, either to press more if the baby is okay and not sick, or to turn the baby, or to move away from the umbilicus. It depends whatever you want to do. So you have to see bowel moving. If you don't see bowel moving, then mostly you have air. So either you compress if the baby is not sick, or you move lateral, you move your probe, the transducer, move it lateral, or you turn the baby. So if you turn the baby to the other side, so for example, if you are looking to the left lower quadrant, turn the right quadrant up. So the air goes to the right, then you can see the left.
Okay.
Okay? Do we agree on this?
Got it, yeah.
When I talked in the conference, there were no time to describe all this. So I skipped some of it.
Okay.
Okay?
I got it.
Okay?
Yeah, I got it, yes.
In the right upper, you will see the transverse colon and some of the jejunum. In the left upper, you will see some of the transverse and some of the descending. And you'll see some of the small bowel, and you can see color Doppler. In the left lower quadrant, you will see some, sometimes you can see the ascending, but mostly you see the descending. And you can see also some part of the ileum. On the right, you'll see mainly the ileum and the jejunum.
Okay.
Okay? And then sometimes you need to look at the liver. At the liver, mainly you see the bladder, you'll see it's very big size something. You can see portal vein. And if you see movement inside an empty lumen, so it's either blood or it might be a portal like biliary tree or biliary canal or biliary canaliculi. So if you're in doubt, just put the Doppler, and if it change the color to blue or red, then this is a vessels. And if it's a vessels and there is air, then this is a portal venous gas. So in the liver view, in the right upper quadrant, you have to look to the liver. If you're looking to the bowel, you use the high frequency hockey stick transducer. But if you're looking to the liver, to the deep structure, you will use the curvilinear, the low frequency transducer.
Okay.
Okay?
Yes.
So the approach is as follows. Start searching slowly and apply a steady pressure. In addition, the reason for that, to displace if there is air, and also you will see the bowel is moving. So if the bowel is not moving, then it's probably a fixed bowel loop. Or also, if you're suspecting intramural gas or pneumatosis intestinalis, when you do some pressure and then you release, it will return to where it was. It will remain there. But if it's intraluminal, then it will disappear. In addition, you will get rid of any gas, because when there is gas, you don't see the bowel. So you slowly and with some steady pressure, and then you start from upper quadrant. And so you don't move when you do your searching, you don't move and jump. So if you're looking to the large bowel, you will do like something like Y shape. But if you're looking to the small bowel, you see like something you're leaning the more approach when you do your garden.
Okay.
And these are the two types of probe, the hockey stick, the transverse raise or the transducer, and it's at the high frequency and looks like it looks for the superficial structures. And also you will use the curvilinear, which is small, but it's a high frequency, so you can look to the deep structure. You will see the aorta or the superior mesenteric artery, but also you can look to the liver and you'll see a portal venous gas with this. Okay?
Yes.
You need to adjust your gain, your size of the picture. You get small, whatever it's small or large, the caliber remains same. The centimeter calibration remains same. Okay?
Fine. Yeah, fine.
We've talked about this, the transducer characteristic, the small and which one you use. It's a text for you to read. What you look for, now you know what you're doing. You're using 5 quadrant in addition to the umbilicus. If you're looking to the large bowel, you do inverted Y shape. If you're looking to the small bowel, you do looning technique. And in each quadrant, when there is an interesting area, you do transfer and perpendicular, and you have to take a color one too, and you do clip, not pictures, so you don't press freeze and then print. Instead, you press save, so you can store as a clip. So you've done all that, you know that. For small superficial structure, you will use the hockey stick high frequency transducer, and for deep structure, aorta or supramesenteric artery or liver, you will use the curvilinear low frequency transducer. So that what you're looking for. First, you look to the bowel wall texture. Is it thin? Is it thick? Is it fixed? Is it moving or not? Then you look to the peristalsis and you divide the peristalsis to 3 types. Is it wormy, it's moving like a worm, or it's oscillatory, the wall is not moving but the content is moving, and the content can be fluid or stool and can be air, or there is no movement at all. Then you'll see pneumatosis intestinalis, PI. You'll see portal venous gas when you look at the liver. You look to the free abdominal air, and you look to the free abdominal fluid. You have to assess the flow in the superior mesenteric artery, and you have to do pulse wave Doppler or bowel wall perfusion through color Doppler. Okay?
Yeah, okay. Fine.
Or confused?
No, it's okay. I got it.
Great. When you look to the bowel wall in anatomy, you have 5 layers. It's alternating hyperechoic, hypoechoic, hyperechoic, hypoechoic, hyperechoic. Mucosa, lumen interface, mucosa, then the interface between submucosa and mucosa, then muscularis, the muscle area, and then the serosa. But in reality, either you see 1 or 2 lines, because the hypoechoic areas, most of the time you don't see it. For example, mucosal lumen interface, you will not see it. You will not see the muscularis, and you will not see the mucosa itself. But you will see a wall sometime one density, and then you have to measure it. So you freeze it, and then you measure, depend on the machine you have. The wall should be, the normal wall should be 1.1 to 2.6 millimeter, or 0.11 to 0.26 centimeter.
Okay.
That's the normal. If it's more, it's thick, then it's either you have hyperperfusion, or you have edema, or you have hemorrhage, or you have infection.
Okay.
If it's thin, then that means start to slough. You're losing the wall, and it might lead to perforation. So when you see thin area, you have to monitor it for evidence of perforation, in addition to the other action or medical management according to the case.
Yep.
Okay?
Yes. Yep.
We've talked about this, and this for you to read.
Yeah.
The usual color Doppler velocity of the wall of the bowel is 0.086 centimeter. So it depends whether using continuous or pulse Doppler, and I think we've explained what is the difference. The difference between pulse Doppler and continuous Doppler is, in continuous you are looking to all the structure in the way of the ultrasound wave, while in pulse Doppler you select a window through this structure. So if you are looking to a line, and this line is graded from A, B, C, D, and A is the superficial structure, and D is the deepest structure. If you're doing continuous Doppler, you will look to all of them at the same time, and you will not see, and you will not differentiate between them. Okay? Which means you don't have a gate. So you measure all the time of the beams of the ultrasound going and coming back to you. While in pulse Doppler, you will concentrate either on A or B or C or D, and you ignore the rest. So, and then you should have a gate concentrated on D to look at this D and ignore the rest. What does that mean? If you put your Doppler over let's say 0.5 seconds, so you measure the beam of the X-ray that coming back to you within 0.5 seconds. Okay? So if the ultrasound can penetrate to all these structure in 5 seconds, you will see them all, and it will be a pulse continuous Doppler. But if this only measure A and B and cannot measure the rest because the time needs longer time, then this is a pulse Doppler. Does that make sense to you? Or is not clear?
Confused.
Confused.
Yeah, it's not clear.
Not clear.
Yeah.
So let's do it in another way. Assume you are looking ahead to 4 people standing in ahead of you.
Okay.
Person A, B, C, and D.
Okay.
Okay, and you are looking to them at the same time.
Okay.
And they are looking at you and speaking to you at the same time. Will you recognize any of them?
No.
You will see them like choral because they are speaking together.
Yeah.
That's a continuous Doppler.
Okay.
If you have ability to shut up A, B, and D, and you're only listening to C,
yes,
because you're putting the gate on that and you're ignoring the rest, that's a pulse Doppler. So what you're doing, you are shortening the area that you can see and you're ignoring the rest. That's the difference.
Okay.
How you do that?
Okay.
It's a time, because the time you need to move from person A to D, let's say 0.5 seconds, which means person A will be 0.1, person B will be 0.2, person C will be 0.3, 0.4, and person D will be 0.5. Okay? So if you put your gate at 0.5, you will listen to all of them. But if you put your gate to 0.3, then you will listen only to C. You get it? You're ignoring 0.1 and 0.2 and 0.5.
Yeah.
That's pulse Doppler. That's the difference.
Okay.
Okay? So the difference in pulse Doppler, you will concentrate on one area and you're ignoring the rest. Okay?
Okay.
So if that area is big on you, let's say you're looking to a wall of 2 meters and you're making your gate 1 centimeter, you will only look on the 1 centimeter. You will not know the rest. But you will have very clear image of that because you're doing pulse Doppler. While if you're widening it all, you will be continuous Doppler, but you will not see in detail. Got it? So that's what we call it aliases. So when you put it on that area and you don't see the rest, that we call it your aliasing, because you cannot listen, you cannot see what the rest. So the ultrasound assume that you are not seeing it or it's not existing and it become mirror image and it's built it on the other side. You call it aliases. So and to do aliases, to avoid aliases, either you widen your gate. So if it's 0.4, you make it 0.5 or 0.6 or 1 second, or change to pulse Doppler to see it all.
Okay.
So when you do Doppler, to read the Doppler, you either use it in trace, so you do trace, and remember we have positive and negative trace, or you make it Doppler, color. So when there is aliases, when there is no aliases, you see red and blue, very good colors. When there is aliases, you will see many other colors. You'll see green, you'll see yellow. And if you're doing trace, if it's positive, it will be cut from the positive and add to the negative. And if it's in the negative, it will be cut from the negative and will be added to the positive side. That's what we call it aliases. To solve this, you widen your pulse Doppler or you switch to continuous Doppler. Is it clear now?
Is there any diagram for it, Doctor?
Yeah, we will see it.
I think so. It's better than.
Yeah, we'll see it.
Okay.
You will see it.
Yeah.
Okay. It's easy to see structure when there is solid area. So beside the bladder, beside the liver, beside the kidney. Okay? So if you cannot see, try to see which area is near to you and try to contrast it with the solid organ so you can see better whether you want to look. So these areas are either side of the bladder So on this side, you can see rectum. On the other side, you can see ascending colon. Near the liver, you can see hepatic flexure of transverse colon. Remember all that. When you put Doppler, okay,
Yes.
when you put Doppler, you will count how many color dots you can see. If you see more than 9 in 1 centimeter, and you will see the measurement, there is scale on your picture. If you see more than 9 dots, then it's hyperemic. And remember, this is a study, so it's not absolute. It's a study done by a person from Toronto on 26 patients. And he invented this number. And he said, if you don't see anyone, then you are hypoperfused. So if you see from 1 to 9, they are mostly normal bowel perfusion. More than 9, you will see hyperperfusion. Okay? And the velocity should be, to do that, on a velocity about 0.08 or 0.86 millimeter or 0.086 centimeter per second. So you have to adjust your velocity when you do this Doppler. Okay?
Yeah.
When you look at the bowel, you'll see the skin, and then you will see an area between the skin before you see the first bowel wall. You'll see subcutaneous tissue, maybe muscle, but you will not see it on the ultrasound. Okay? So what you will see, you'll see linear hyperechoic area, and then you will see lumen. And if you're good, you will see hypoechoic area. So you can see the lumen here. This is the lumen. You can see the wall, and then hypoechoic area, and then you'll see muscularic area. So this is a wall of a bowel, okay? It's very magnified. So if you're lucky, you can see 3 layers: hyperechoic, hypoechoic, hyperechoic. Okay?
Hypo. Yeah.
You cannot see the all 5.
Okay.
So normal bowel thickness, 1.2. Remember, abnormal, less than 1.1, more than 2.6. And also this will change with the gestation. So,
okay.
Because remember also this is like a study. So the thickness will increase with the gestation. So, and that's why this range from 1.1 to 2.6, because also gestation interferes. Like a term baby will probably have 2.4 to 2.5 to 2.6, while like 24-weeker will have like 1.2, 1.3. And this is a 24-weeker, and you can see the thickness is about 1.6. And remember, the measurements sometimes have some subjectivity. Okay? And also when you start, so this is the line. And you can see here, you can see air in the lumen. And when you see air in the lumen, you'll see a comet tail. Okay? You can see shadow. Okay?
Yeah. Yes.
Again, this is a talk about how we do it. This is a text for you. This is show you also the colon. You will colon and you will see a hostry. You see this?
Yes, doctor.
So when you see a hostration, this is mostly a small bowel. When you see it
Small
flat
bowel.
and big, this is mostly colon or large bowel. And that's the only way to differentiate between large bowel, wide caliber, and absence of hostria, or a projection with pedunculated projections. Okay?
Yeah.
Of course, you have to review it and then ask me questions before we go to the next session.
Yeah.
Also, this is explaining what we, or like right side, an explanation or a text about what we've said right now.
Okay, doctor.
So again, you can see ileum, small bowel. You see the hostration. You can see the jejunum in here. You can see the projections. And this one is a colon. This is a colon. There is no projection, but you can see these points of muscles. Oops. You can see this is a big colon with some stool. If you're suspecting this is a hostility, you have to move a little bit, do some compression to make sure this is a stool not attached to the bowel, to differentiate between presence of a stool or hostility. Peristalsis, we've talked about it. How we see the peristalsis, you see three things. First, you see wormy movement with bowel content and bowel wall, peristaltic movement with only the content moving, not the bowel wall, and that's what we call it oscillation. And then you see no movement, fixed bowel, no movement of the bowel wall, no movement of the content. And that would be or what we call it fixed bowel loops. And usually we know that on the X-ray by doing 2 or series of X-ray within like a few hours period. Okay? So we call it effective bowel movement, ineffective bowel movement. Compression to differentiate between intramural versus intraluminal gas, or what we call it in ultrasound pseudo-pneumatosis intestinalis, or the bowel lumen gas. Okay?
Okay.
And also it will differentiate the intraluminal from intraperitoneal gas. Intraperitoneal gas, you will see it either as a single dot, hyperechoic, or you'll see bubbling, or you'll see acoustic shadow. Because remember, if the gas in the lumen or in the peritoneum is not limited by a wall, then you'll see a comital, you will see a shadow, or what we call it acoustic shadow.
Yeah.
And that you will see it below the skin, if there is intraperitoneal, above the liver, between the liver and the spleen, between the liver and kidney, beside the bladder. That's the area where you look for intraperitoneal gas. And remember, if the baby on his back, the gas will be near umbilicus if it's on the skin. And if you want to make sure it's luminal, you turn the baby. And if you turn the baby, it will move because it will go to the right side or the left. It depends to where you turn your baby. And that you all know it's not intraluminal, it's intraperitoneal. So it has either single or bubbling or acoustic shadow. Bubbling, you see it moving. Single dot is staying stay. And acoustic shadow. If you're confused, is it intraperitoneal or intraluminal, you move the baby. And remember, the gas will be on the independent area. So if the dependent area is the bag, then the gas will go to the front. And then you'll see it mainly in the independent area, above or below a solid organ. So either below the skin, or above the liver, or between liver and spleen, or between spleen, liver and kidney, or between spleen and the kidney, or on either side of the bladder. And that's what we call it dynamic exam. So dynamic exam, you do it by 2 ways. Either you compress by your transducer, or you turn your baby. That's what we call it dynamic serial studies. To differentiate between gas in the lumen, gas in the wall, and gas in the peritoneum. Gas in the lumen, if you compress and then you go back, it will disappear. While gas in the peritoneum, if you compress, it will not disappear. It will disappear when you move the independent area. Okay? While gas in the lumen, it will stay in the wall, or nematosis, it will stay in the wall. Gas in the lumen and gas in the peritoneum, we call it pseudo nematosis intestinalis on the ultrasound. Are we clear?
Yeah, yeah.
Are you confused?
No, it's okay.
Good.
No, it's okay.
So you don't need to be very smart to know that this is a normal bowel moving and this is a sick bowel. It's not moving and it's echogenic and it's more white and more clear and a little bit sick. So it's a little bit thick, and this is like normal, and this becomes sloughing. Mostly it will perforate. And this is sick, edematous, probably there is hemorrhage in it, and this is a little bit normal. And this is a normal too. But this is start to be very sick. This is a normal bowel, very swole, and many is moving together. This is a, by the way, this is a colon, and this is a small bowel. You can see the hysteria here. I don't know whether you see it or not. In here,
yeah, I can
this is small bowel. Yeah. This is small bowel. This is probably a large bowel. This is very sick bowel.
Sick bowel. Yeah.
Okay.
Yeah.
And we're done with the session number 1.